Hello.
Hi, Lily.
Hey, how are you?
I'm doing great. How about yourself?
I'm good. So we're gonna give a couple minutes for people to join. It is 4:32. How is your day going?
It's been good. It's been good.
Good.
I've been excited and a little bit nervous to be doing this with you, but I'm excited because I'm a fan of your IG and I've got caught up to watch all of your videos and I just think it's awesome, like what
Thank
you're
you.
doing. So I'm glad to be a part of it.
Thank you. Thank you. I'm glad you're here visiting the Brain PT platform. And this week we are now more than 600 followers in this
Wow,
community. So it's been going great. So we're
that's big
just
time.
building up this community and growing every day. So
Great. Well,
starting the new year.
now I'm just more nervous now.
No, no. So we're gonna wait a couple more minutes to see if I know at some places like in California, it's kind of the middle of the day. So for everyone who will be watching, this video will be posted in the page just for reference for the future. So we'll give one more minute to see if we have a couple more people, and then we'll get started. Hello, Delane. Delane is joining us.
Oh, hey, Delane.
All right.
I'll share my funny story
Yeah.
publicly now because the other day I was like, I'm not very savvy to Instagram other than just like flipping up and down. So I was trying to play around with the live the other night, and I must have like started going live because then all of my kids at the house, they're like, "Dad, you're going live!" Like I didn't even know I was.
Yeah.
I was like, I didn't mean to do that.
Oh, that's
But I'm
funny.
catching up with the kids. I'm getting it now.
You're catching up, yes.
Hmm.
Oh, that's funny. All right, so we'll get started. Hello, everyone. Once again, we are here in another IG Live, and today we have Jimmy Moody. He's a neurotherapist. He has been an NCS since 2011. He is a certified brain injury specialist trainer. He serves on the board of governor with Academy of Brain Injury Specialists. He's part of the Texas Brain Injury Advisory Council, and he is the CEO at Cobalt Rehab Hospital. So welcome, Jimmy. And this was just a quick intro, but tell us a little bit about you and what are you doing now, and maybe like a fun fact about you.
Okay. Fun fact: I'm just learning how to use Instagram Live.
Okay, good.
No, so I mean, professionally, I started as a PT. You and I graduated from the University of Texas at El Paso. I got out of school back in '05. At that time, I was thinking very much like manual orthopedics. Biomechanics was fascinating. And then when I was working in an outpatient clinic for the same company that you work for now, I just kind of started falling in love with the neurological rehab process, like from the assessment. Like it was more than a joint assessment and mobility. And I think like some of that biopsychosocial assessment really integrated well into like neuro assessment. So long story short, just fell in love with that, passion for that. Got to work outpatient, acute, inpatient rehab, skilled nursing, like a variety of settings. But along the way, it was always something neuro driven towards my practice. And 10, 11 years ago, maybe 12 years ago now, I started working with Mentis, which is based out of Texas. It later was bought by Neurorestorative, but it's a post-acute brain injury setting. So working with post-acute brain injury after the patients have been through acute care rehab and then inpatient rehab. So working in that environment for a long time and getting to see the persisting sequelae, but also just, the recovery process and how long it can go on for. And it really is, recovery for a lifetime.
Mm-hmm.
So with the passion, you can't help but want to get involved in other ways, like not just from a treatment standpoint, but, being, so that kind of led me to join in with the Board of Governors, with the Academy of Certified Brain Injury Specialists, which I'll reference their text here later on today. In Texas, I'm now on the advisory council for brain injury to help with legislation and push legislation in Texas. So again, I mean, there can always be a push for greater care and more resources for persons with brain injury and their caregivers and loved ones. So trying to be on that front in Texas. And that's lent itself to just networking with a variety of clinicians, all disciplines, different states, some international work, and just getting to meet new people that are on the same mission, passionate like you, Lily.
Yeah, so brain injury rehab is such an amazing field. And today's topic is something that at some point we all struggle with. And I've been there, you've been there, and I'm sure a lot of people who work with brain injury survivors have been there. And today's topic is how to manage agitated or inappropriate or both behaviors. So tell us a little bit about why does agitation or inappropriate behaviors happen?
Yeah, I think you even just in your first couple lectures here with the ranchos, you went into deep detail about the physiology and the metabolic cascade and just some of that physiological healing. So depending on where you as the clinician are seeing that patient in their recovery, if they're in coma, they're emerging out of coma, where they're falling in that ranchos, how many impairments they have, not just cognitive. Is there polytrauma, broken bones? Is there pain that's a factor, headaches, craniotomies? There's all sorts of examples that probably could come to mind. And at the same time, we could probably wrap this whole presentation up into behavior. Like, what is the behavior? And is it an agitated behavior? What does agitation look like? Is it inappropriateness? And then you can really elaborate on, well, what's inappropriate about it, which I know we can, talk more about here. But what is the behavior that seems to be problematic? It's thought that all behaviors have some purpose. They serve some purpose, even in the maladaptive ones. So yeah, I think it's an important lesson, whether you're calling agitation, where you're saying this is, or it's a sexually inappropriate comment, or if it's physical aggression or property destruction or self-harm, like whatever behavior you start looking at, you want to be able to define it and say, okay, what is it? What is its purpose and function for that person? So I think probably just to kind of answer your question, if we put it in the context of ranchos for, confused and agitated, that's like, to me, that's what I think people think of when it comes to brain injury. When you say, oh, somebody had a brain injury, they think of this very erratic, physically aggressive, pulling out lines and tubes. And that's the part of the brain injury that people might think of when they hear the word brain injury. Fortunately, that phase often, people move past that phase. It's very hard.
Or they might skip it sometimes. Yeah,
they could. They can move through it really quick where it's not even noticeable. And also, the thing is, when they start to have these behaviors that they don't remember, a lot of times down the road, somebody will tell their testimonial and say, oh yeah, the nurse told me that I was pulling out lines and cursing at them, and this is like the sweetest person, they would never do this, but they're embarrassed because they did behave that way.
Right.
So yeah, so in that stage 4, you're probably looking at what behavior is it, how are you managing it. It's probably outside the scope of this presentation to talk about like all the pharmacological management of that as somebody emerges out of coma into level 4, and how you might manage that with pharmacy.
So what is agitation?
Yeah.
How would you define agitation?
That's a great question, because you can ask me and I'm going to give you my answer, and then somebody else might be asked and they might say something else. So I might say agitation it's still a behavior. If you were to say, Jimmy, are you agitated right now? It's probably because you're picking up on something, like some body language. Like, am I am I kind of like rolling my fists around? Am I kind of getting tense? Is my posture changing? I'm going to show you some signals that I look agitated. And that's like the physical appearance. Agitation could also be like, I'm starting to avoid eye contact now. I'm disengaging. I might give these indicators that I'm growing agitated. And I think those are the subtle signs of agitation that you might see in somebody, even without a brain injury, right? You see someone that's being irritated. So you can watch for those signals, because, you can't see thoughts, you can't see emotions. You can hear people express like, oh, I feel sad. You can see somebody crying. You can see somebody pacing because they're anxious. So you can observe these behaviors, but because you can't see thoughts, you can't see feelings, we make our assumptions about what is that person feeling right now. They're agitated. And if someone's agitated, us the caregiver provider, we would like to ease that agitation in some way, so that's the next question is, well, what do we do about it? What do we do if someone's agitated? So Lily, you and I have had several conversations too, just what do we do with somebody that's agitated in front of us? What do you do with someone that's pissed off, basically? How do you calm them down and do it in a way that's professional? Because I'll speak for myself. Like when I've been in a situation where a patient has become physically aggressive, verbally aggressive, like verbal outbursts, cursing, criticizing me, shouting, stuff like that, I still have a human fight or flight reaction. It's not like I'm immune to that.
Yes.
I think that we as males and females in healthcare, we face a different experience. Females are probably more subject towards the sexual inappropriate comments, a male patient making a pass at them, groping, grabbing, just really making somebody feel uncomfortable. For men, I think that we might draw the other side of a male, let's say a male agitated patient out. It could draw out the fight mode in them and they want to get verbally aggressive, physically aggressive. Maybe that's not how they would react to a female. They would do something else. So just kind of like detecting the early signs of irritation or whatever this behavior is, right? Because once you can determine the precursors to that, then you can do something about it before the behavior even occurs. So for me, like what I try to keep aware, awareness is a good word for it because I'm just aware of my own reaction. I've practiced remaining calm, using validating comments to try to de-escalate somebody that starts to get agitated.
Such as which comments?
So I might say things that are validating to say, that sounds really frustrating.
Okay, so validating their emotions.
Yeah, I might just say, okay, so I'll even be more specific. So what you're telling me is you've been in the hospital, you've been away from your family, you feel alone, and you feel helpless. And sometimes when you like hit those points on that person, it almost softens them up because they feel heard. So I think some of those things are helpful in de-escalating, validating the things that they say, validating the things that they feel or say that they feel. That can help soften somebody up so that you're not the threat. You're an ally in their recovery. It's also helpful for me to remind myself like that I am part of their environment. They might be lashing out just because they're angry, and I'm experiencing it because I'm part of their environment now. I mean, they don't have their loved one to share their feelings with, their frustrations, the good, the bad, the ugly, so we are kind of their only mode, to get some of that out. So to really try to depersonalize it, not make it feel personal. It's not that they don't like me, Jimmy, because as healthcare providers, right? Like we got into it for a reason.
We get hurt.
What? You don't like me?
That you're telling me I'm this and that. Yeah.
For sure. I mean, we're helpers by nature. We have a caring and empathetic kind of a spirit about us. So, when something like that is the opposite happens and people are trying to be hurtful towards us, it helps to remind ourselves, it's not personal. Like this person is going through their recovery and there's reasons for that. The flip side of that coin is that those type of behaviors can also become problematic later on down the road. So it ultimately becomes our responsibility in healthcare to also help coach and shape our patients' behaviors as best as we can, to set them up for success and healthy reintegration back to family, whether it's them as a child in the family, a parent, a sibling, or whatever it is, a worker, reintegrate back to community. So we can shine the light. We can help shine the light on some of those things. John, every time we have a conversation, I notice you interrupt me. Have you seen the same thing as me? And like if I were to have that conversation with, Uncle John, out at the next wedding event, you know what I mean? Like in my family, like I'm probably going to offend them, right? It's not a normal conversation that you have with people. We usually keep that stuff to ourselves. But when it's within the scope of our practice to say, can we help build awareness around this particular behavior, not for just the sake of pointing it out, but then in turn doing something about it, then that person can actually, it's beneficial. It helps them in the long run. So I think, in being in neuro rehab, that was one of the things that I found naturally is a good skill to have. I think naturally, I was already pretty good at listening to people, but to be able to engage in those really uncomfortable conversations that people don't have, we may not talk about sexuality during this presentation, but man, that's a huge thing that healthcare neglects to address with persons with brain injury and other, we don't talk about it. Intimacy and how they can reintegrate back to romantic lifestyle or romantic relationships and things like that. So
what about when our patients get more like the physically agitated?
Yeah, the physical aggression, I'd refer to, there's a lot of programs out there for behavior. So there's behavior modification and there's de-escalation strategies. There's behavior shaping, where you could talk about positive reinforcement, negative reinforcement, and this very strategic and methodical approach to shaping behavior. Like for the example that I just said, the interrupting, turn taking, that's a behavior that could be shaped. But what do you do about the behaviors that there's physical aggression, there's self-harm, there's those really intense behaviors that are considered high-risk behaviors, which are self-harm, verbal outbursts / physical aggression, property destruction. Because even if you look at sexual inappropriateness, that it typically doesn't cause physical harm. There's tons of hurt feelings around it, and there's lots of problems with it, but there's not necessarily physical harm. So those high-risk behaviors, there's programs out there. One of them is CPI. There's also Sartori. There's programs out there that you could literally just Google like behavior modification, and they come with the behavior modification skills, which is your cognitive skills as a clinician, how to manage that person. And then there's the physical skills. And the physical skills would include, how to restrain a patient, how to constrain them, like maybe like holding techniques. And those are always thought to be last resort. Try to do everything else first to de-escalate. But when you have a patient eloping out of the building and they're about to walk into a street, you have no choice. You have to go physical techniques.
Right.
So yeah, so there's a lot to it. I mean, we, in my previous position, our training was through an organization that focused a lot on physical, and we would practice these skills on a regular basis on each other, and just like your CPR, but we would practice them legitimately. I mean, so you got used to being able to react to somebody that was becoming aggressive. One of my war stories was that we had a gentleman that had a knife. He just happened to have a knife on him for fishing, I think is what it was. But once he took that out and he was in the hallway, we had to have our reaction, which was, separating the patients, make sure everyone was safe and all that stuff. And then we had to do some physical techniques. So it was just myself and another team member. And we just kept in communication on how we did that and how we were able to to be able to wrap him safely, keep him physically safe, and then still be able to, get the knife away from him and all that. And that sounds like really intimidating probably, but the point is, and the answer to your question is, there's skills, there are skills out there that you can learn and practice so that you're prepared in the event that those things happen.
Yeah. And I've been through that CPI training. And for those of you who haven't heard about this training, this is just like a training that they teach you how to, like Jimmy said, like constrain and restrain a patient if they're like, grabbing onto you or like holding your hair. How do you get like out of it and things like that. So it's like a physical training. So they teach you those skills, which are very good to have if you work with brain injury survivors. So and then for, let's say if a patient is agitated, like getting physically aggressive in the acute care, what is like, one or two tips that you can give us, and like if like they're punching or they're like holding us, and because I've had some patients that are not brain injury survivors, but let's say they kind of like do this to me, like give me your hands, and I do, and they squeeze my fingers like they want to break them, and I start to feel like, oh my God, they're gonna like hurt me. So what is like one, two tips, like nuggets that you can give us for like acute care?
Yeah. Man, I mean, there's so many things that come to mind. I mean, so situational awareness, like be very aware of your surroundings.
Where you are. Mm-hmm.
Yeah, which probably we are. I mean, as it is like in acute care, you're like, is there a Foley bag around? Is the IV attached? Like you're already aware of the patient's physical condition and their environment. Mm-hmm. You probably add an extra layer of awareness because this person can turn violent on you. Mm-hmm. So that's the tip is situational awareness, but keep distance.
Mm-hmm.
Arm's reach is going to be about like 3 feet or so.
Right.
So if you keep a good 3 to 6 feet, the patients will take a swing at times, even if they don't, again, like the sweet person will tell you they didn't mean to, but they did, that can happen. So if you keep arms distance or further, I know physical therapists have trouble because we're tasked with gait analysis and standing balance, and you have to be up in their business, so same thing with OTs. You're doing like ADLs and dressing and showering. I mean, you get close in their personal space. So that awareness helps when you can keep distance, at least till you start to assess the patient to determine like, are there any potential triggers that lead to escalation up to physical aggression, violence. But yeah, if you can keep your distance, you mentioned the hair. So for if you have long hair, keeping everything wrapped up. If you wear jewelry, try not to have loose jewelry on you, because man, they can get a hold of your necklace, even like your badges. They grab a hold of your badge and grab them whatever they can. So I mean, it's just that type of awareness, like what can be used as a weapon. And this is again like in the context of a patient that you're still trying to figure out if they will turn physically aggressive or violent with you. And usually in hospital settings, there's codes like code strongs, and then there would also be pharmacological intervention on board as well, whether they're using antipsychotics or something to manage that patient's behavior. But yeah, just definitely be careful, because even if you end up in those situations and you understand like, oh, this person's reacting because of their injury, they're confused or whatever, they can still cause harm,
Right.
So gotta be careful.
Yeah. We have a question here. Where can they teach you, or where do you take the course for CPI? So in my case, I took it at on my clinical rotation for school. Do you know, Jimmy, where can you get like trained for the CPI training?
Yes, I mean CPI has their website. So if you just type in CPI into your search engine,
what does it stand for?
Oh, I was hoping you weren't going to ask that. Something intervention. So, I didn't get CPI. That's why I didn't. And I think a lot of CPI also there's de-escalation, and you can apply it to children as well, like pediatrics.
I will find out, and I will share with you like on the story for those who are wondering CPI.
Yeah.
All right. So now we're going to talk about inappropriate. And then if we have time left, we'll explain a little bit about the outcome measures. But now we're going to talk about inappropriate. So I'm sure now, as you know, any neurotherapist has been through the experience of someone saying something inappropriate. And this can be also seen in people who had a stroke, in people who had a brain tumor, in people who have, dementia. So it can be seen not only with brain injury survivors. So like I was telling Jimmy a long time ago when I was with a patient, and this patient had a stroke, and this patient just kept perseverating and asking me, are you married? Marry me. And, you're this and you're that. I'm going to, build you a house, and please marry me. You're this. And, like you said, your fight and flight is like, oh, like, what do I do? Like, do I ignore it? Do I address it? What things should I say? What things I should not say? So can you give us like a short, like, tips on like how to address an inappropriate behavior?
Sure. Yeah. And I think, you know, like the example you're giving with the sexual inappropriateness, I mean, that one's probably very common, and I'm sure you could provide some insight on that because, you know, like I can't tell you what it always feels like. Like, will somebody will a female patient make a pass at me sometimes? Yeah, sometimes. I mean, but um, I would say that probably you and other female healthcare providers have experienced that a lot more. The general tip, you know, that we've talked about before is the one thing that people will say is don't do that. That's inappropriate, right? You know, it's kind of an authoritative response to the situation to say that's not appropriate, and it does have a parental feel to it. So when you're addressing children, adolescents, that type of talk is probably appropriate. But once you go adult to adult level, it's different. You know, when it has this authoritative
Right.
feel to it. In fact, it probably might even trigger somebody to respond like that. But it also, even when I went through school, I mean, that's what I was taught was like, tell the patient they're
Me
inappropriate.
too. Right.
So it's like
But
the
it just
most.
feels like to me it feels unnatural. Like, don't do that. It's inappropriate. I just feel it's like, is it really going to work? So what's your advice to us?
I would say make them aware, and this is now applying to brain injury, frontal disinhibition, where maybe they don't have that filter and it's coming out. It can help for you to return their comments to them and just say, you just said this to me, you know, that made me feel this way. You know, you said I made me feel uncomfortable. Is that what you meant to do? And sometimes it's that simple. And again, this isn't normal talk. Like we don't talk to people out there in the community like this. So I do recognize that this is not natural or quite normal, you know? So, but just by putting that back to the person, you're kind of stopping them to reflect on, was that their intention? I found, and through talking with other, you know, therapists that have had this situation happen to them, when they use that, it seems to stop after that one time. You're essentially drawing a boundary, you know, so you're boundary setting. The problem is though that patient may do it again tomorrow. They might do it to another female staff that comes in right after you walk out the door. So it can be very context specific, but that's a really quick way just to reflect it back on them. You can go a different level and just say, you know, you also have a wife, you have a daughter. Would you like somebody talking to them like this, right? Now you're making this more of a complex explanation and really trying to make it personal. Your intention isn't to shame them. Your intention is to build awareness around that behavior so that they can hopefully control it within their own mind and not talk like that. So when they go out there to a restaurant or they go out back to their workplace, you know what I mean? So it has good intention and there's a way to do it respectfully and with integrity.
And just so you all know, Jimmy gave me this advice and it worked the first time that I used it with that patient. He stopped saying all these comments. I don't know if he said it with somebody else, but with me, he stopped. So that really worked for me instead of don't do that, you know?
Yeah.
So what are some things you should not do or you should not say when someone is telling you something inappropriate?
I would caution you not to say nothing. And so what I mean is a lot of times people, and this is true for me too, you know, like I'm saying this with looking back on my own past reactions, is it's uncomfortable, so I avoid it. I don't confront it, I avoid it. And
so don't ignore the behavior.
Correct.
Yeah, okay.
Correct. Now, now there is an argument against that, and I'll just get it out of the way. So there's a behavior modification technique known as extinction. And the best, simplest example that I know a lot of people relate to is like the child crying in the restaurant, let's say. They're throwing a fit, they're having a fit, and the parents just say, okay, don't, just ignore him, and then that crying will stop, right? That fit will stop. That's an example of extinction. So if the parents are united in that example and they say, okay, well, we're just gonna ignore it, then the behavior will stop eventually, but it'll stop with just those two parents. Extinction is very context specific. So now that child goes to grandma and grandpa's, does the same thing, they get their lollipop.
Right.
So the reason why I'm discouraging it is not because it doesn't work. It's just very hard to execute and to sustain that behavior tactic. So I think that confronting it can be done in a way that, again, is like you're trying to shed some light on it. The caution is that you won't know how they're going to react to that feedback until you give it, you know, the first time. So tread lightly, you know, make sure you've already established a rapport with that patient or you're establishing rapport. I kind of find for myself, the less authoritative I am, the better.
Mm.
Meaning, yes, do I think that I have expert skills and knowledge to help this person? Yes. I don't want to discount that. But if I sit there and I come across that way as I'm like, and say, well, Lily, the reason why you're acting like this is because you had damage to your left frontal parietal lobe, and there's this disinhibition, and the good news is that we're going to fix it because this is how we're going to do it. I don't think that works as well as, what I noticed that you said this yesterday, or you said this right now. What do you think about that? Like, take on curiosity as your teacher, and that you're learning with that patient, because you're not threatening them. You're not, if you're really asking the question authentically in that moment, and I think it comes across like that, then you might engage the patient with that type of thinking. And the second benefit of that is that's how you can treat them. That's how you can continue to rehab them, is by asking them the questions right there by their side. And whether you're talking about a cognitive dysfunction, like, impaired memory, or you're talking about this behavior that might become problematic in the workplace or their relationships, or you're talking about how do you improve your gait pattern. You start it with, I notice this is going on. What's your take on it? And you engage the feedback. Self-regulation, right? I mean, you get them start self-regulating.
Yeah. So, wow, those are great advice. And if you, the audience, haven't tried this technique, I recommend to try it. And remember, don't give up if it doesn't work the first time. Just keep trying. Eventually, they will become aware of those things that are happening. So lastly, we're going to just cover really quickly. We have about 5 more minutes. We'll go back to agitation. For those of you that work in acute care or, an inpatient rehab, there is a scale that is called the agitation behavior scale. And this is what we use to measure the level of agitation. So Jimmy, just give us a little bit intro to this scale.
So this one, I was telling you earlier, we tried implementing it at the last organization I was with, which was more post-acute. So you'd be seeing patients that are more medically stable. They might be Ranchos 5, 6, 7, 8 beyond. So it didn't really fit as snugly in as you might use in acute care or an inpatient rehab or an LTAC or skilled nursing per se. But it's still a systematic approach. And what's good about it, whether your organization or your team decides to use it or not, is it gives everybody the same language to use, and that you're scoring it systematically, and there's a score. So it's, it's at least gives you that data that you can track across the course of days to weeks, on what level of agitation. But it's a 4-point scale, and you chart it in the morning and out in the afternoon. And then as you track that data, you can trend it to see what that numerical score is. Is it reducing? So basically, yeah. So the higher the number, the more agitated they are. So you want that to all trend down. Yeah. It also takes some training. So you don't want to necessarily just say, okay, here's the agitated behavior scale team. Go ahead and start using it tomorrow. I mean, you want to get a little training on it so everyone's using it reliably.
Yeah. So yeah, it's an observation-based scale. And just to give a little bit more detail about it. So if you have a score less than 21, we said lower the score is better. It's usually considered within normal limits. But if you have more than 21, getting towards 35 and beyond, that is agitated. So 21 and starting like 22, 23, 25, yes, that's mild. And then as it climbs up, it's more severe. This is what we use for agitation. All right. Well, anything else that you want to mention? This was great. Thank you so much. Anything else that you want to like not throw up, but some information for us?
Yeah, no, I think what we how about this is homework, for people that really like are interested in this, is we didn't get a chance to talk much about the ABC model, and there's other stuff out there. I'm gonna do a quick recognition. So like with ACBIS, brain injury certification. So this is the most recent manual for brain injury, and so it's really, I mean, it's a good Bible, but it's the most comprehensive book that's out there.
Mm-hmm.
because it's multidisciplinary, and there's PTOT, social, speech, I mean, medical, nursing, there's all the disciplines in one text, when oftentimes a lot of texts are geared more towards medical, therapy, nursing, what have you. So that's a great multidisciplinary one. So there's a model in there, but the ABC model, the antecedent behavior consequence,
Mm-hmm.
you know, look into that, because it has very practical approaches as an individual team member, but also across a multidisciplinary team, where you say, okay, the behavior is sexual inappropriateness. What was the antecedent? What occurred before that?
Mm-hmm.
You know,
Mm-hmm.
was the person searching pornography on their phone? Were they already kind of sexually, you know, um, uh, like engaged, and then a staff member walks in, and then
Mm-hmm.
now they're becoming sexual, and
Mm-hmm. Mm-hmm.
then what's the consequence of that? The staff member says, you know, John, what you just said right now, um, was, you know, made me feel uncomfortable. You know, it made me think that you're trying to make advances on me, and I'm a married person. Is that what you mean? So like, you have the antecedent, the behavior, and the consequence, and
Mm-hmm.
it just applies a model for you to use as an individual, but also as a team. I
Mm-hmm.
think the biggest error that team members or even teams make is they go, that patient's behavioral, and it's just very vague, you know, or they
And
have
it's a negative connotation for the patient.
exactly. So if that starts up in your team, then go, well, what behavior are you talking about? Operationally define the behavior, because
Mm-hmm.
otherwise, you know, Lily's going to see that inappropriate behavior as the behavior. I'm going to go in there and I'm going to say, I don't see any issues with him. He seems fine to me. Or somebody might have a different definition of what that behavior is. And you
Mm-hmm.
can have more than one behavior, right? You've got adaptive and you have maladaptive behaviors. So just define it among yourselves, so that when you start tracking it, you're tracking the same behavior to determine if
Mm-hmm.
you're actually making an impact on it or not.
Mm-hmm.
Yeah.
Right. Oh, great. Yeah, that was great advice. And yes, the ABC behavior management, it's a great thing that we should research. And for those of us who are studying for the NCS, this is part of the NCS prep as well. So lastly, one question popped in my mind. If, let's say, someone is interested in becoming a certified brain injury specialist, I know you're a trainer. Can you give us a little bit about how do we become certified, or what's the process of it?
Sure. Yeah. So also search engine Acbis, ACBIS. You can also go
Mm-hmm.
to the brain injury BIAA.org. So that's
Mm-hmm.
brain injury for America, at least, you know, this country. And then you can find the CBIS information through there. So you need 500 hours of care of persons with a brain injury, but that doesn't have to be traumatic. It's any type of acquired brain injury. So you
Mm-hmm.
mentioned tumor, stroke, brain infection, encephalopathy, stuff like that. It's
Mm-hmm.
all going to count towards those hours, much like the NCS. You know, you have to accrue so many hours. So
Mm-hmm.
once you're around that 500 mark, then you can take the exam, or I should say you could apply for the exam, and then take the exam, and then it's a certification, so you have to keep it up, you know, every year to be able to get your CUs,
Mm-hmm.
continue to get the certification. The trainer, you know, I did that because within our organization, we wanted our employees, our team members, to have that extra advanced knowledge. I think the most beneficial thing, other than getting a credential, you know, was, or more than getting a credential, was that it gave the team common language to share.
Mm-hmm.
So when Lily gets her CBIS and all our other team members get their CBIS, they're all learning from the same manual, and you guys start using the same language, and then you start trying the same interventions, and it just unifies the care, which in brain injury, you know, interdisciplinary programming is the most effective,
Mm-hmm.
versus multidisciplinary.
Mm-hmm.
So it's a great certification to get. You can seek trainers out, and like myself, like I can do training remotely now. I haven't been able to do any live trainings, but remote trainings,
Mm-hmm.
and get the information that way too.
Okay, great. Yeah, and I think this is well, now going all virtual, it's easier to find a trainer than
Mm-hmm.
before, so that's a positive thing. So,
Mm-hmm.
well, thank you so much for joining us today. This was awesome. Just a reminder for all of you, we'll continue through the Rancho levels throughout the rest of the year. We just have one more day, but we're missing a couple of levels, and it runs in all the way through January 5th, I think. So thank you, Jimmy, so much. And I
Yeah,
hope that you join us in the future for another topic related to
definitely.
brain injury. And I hope you have an awesome day,
Thanks.
remaining of the day.
You too.
Okay. Thank you.
Bye.
Bye.